Hi, everyone. This is Dr. Kenneth Smith from the Chickasaw Nation Medical Center. I'm thankful for the opportunity to come and talk to everyone about health education, specifically in the federally qualified health centers. So we'll talk a little bit about the federally qualified health center model, some of the resources that it has available, or if any of you work at a federally qualified health center, we'd love to hear from you too. And then some of the ways that you can integrate health education in the care of your patients. So just kind of review on the federally qualified health center. FQHCs are community-based health centers that are funded by the HRSA. They provide primary care in underserved areas. Care is provided typically on a sliding fee based on patients' abilities to pay. And then they operate under a governing board that most of the time includes patients, which is a big thing for the FQHC. If you're looking for titles for community health centers, it's either community health center, migrant health center for the homeless, health centers for residents of public housing. While they have a specific name in their title of the health center, these often have a blended population. Primarily, the goal of these federally qualified health centers is to move toward interdisciplinary care. So in the role of interdisciplinary care, there's often primary care, dental, women's health, behavioral health, also pharmacy and lab services, and radiology services, kind of all under one roof. So we'll talk a little bit about obesity statistics in the United States. And this is the CDC's most recent report in 2020. The earliest data that they could reach back to is 2017 and 2018 that they've kind of conglomerated. And this may be a review for everyone here, but the prevalence of obesity in the United States is pretty astronomical at 42.4%. Compared to 1999 to 2000, that is up about 12% from where it was. And the prevalence of severe obesity, what we used to formerly known as morbid obesity, now known as class 3 obesity, has almost doubled in the United States. The most highly affected population with this disease is non-Hispanic Black adults, coming in at the highest at 49.6%. Followed then by Hispanic adults at 44.8%, and then by non-Hispanic white adults at 44.2%, and then non-Hispanic Asian adults, which tend to be a very outlying population at 17.4%. The age prevalence is more evenly distributed. So the younger populations at 20 to 39-year-olds are typically about 40%, and then the 40 to 59-year-old group at 44.8%, and the patients that are 60 and older at 42.8%. When we're talking about federally qualified health centers and chronic conditions, the obvious question comes up about obesity, type 2 diabetes, and their relation to socioeconomic status. And we're going to look at those individually. When you plot these numbers on a curve, it looks like a bell curve, but I think a better way to describe it would be an inverse bimodal distribution is how it looks. So the lowest and the highest income groups, when you look at socioeconomic status, suffer from obesity the least. When they looked at the data, there's small differences interracially and between different minority groups, but these weren't statistically significant. They were overpowered by the income status. So this seems to be the highest or the largest factor in obesity when we're talking about social determinants of health. And the real question is, why does this happen? And this will be kind of our open discussion, and we can save the questions. If you come up with any ideas or any reasons, we can kind of save those for the end of the talk and just kind of open up the floor at the end here. So what we see in this inverse bimodal distribution is what we call the peasant-king paradox in obesity. So 500 years ago, 1,000 years ago, obesity was truly a disease of the privileged due to access of resources and access to foods. However, today, as we saw in the statistics, the wealthiest among us and the poorest among us trend toward lower rates of obesity. The wealthiest among us trend toward a more health-conscious diet, and that's primarily due to health education. So their diet is primarily low-calorie, plant-based, more akin to something that you would see in a slower socioeconomic peoples of a way different time. What the statistics kind of ignored when they plotted this out was the affluent youth of our world. So with the access to technology and resources and education in the United States, our young people are very, very, very knowledgeable about health practices just because of the availability of health education to them. They're typically in that low income bracket. So that's why the curve kind of skews toward the lower end in the younger people and the less wealthy people. And oftentimes, if they're in college or graduate studies, young tradespeople, entrepreneurs, they have better access to health education. And the key here is health education, not necessarily access to health care, but education about health practices. So I don't know what diabetes is called throughout the rest of the world. It may just be diabetes, but here in Oklahoma, it's called the sugar diabetes. Here we're referring to type 2 diabetes mellitus, different from type 1 diabetes mellitus in physiology and in treatment. Type 2 diabetes is a more predictable model. As the population ages, it becomes more prevalent. Patients become more insulin resistant. They develop more comorbidities. They're exposed to more toxins. They have more cellular damage and more DNA damage that leads to the development of different diseases. About 12% of biologic females, 14% of biologic males suffer from type 2 diabetes. When we look at it based on race and cultural group, the Hispanic population suffers at a rate of about 14.7%. The Asian non-Hispanic suffers at 14.9%. The non-Hispanic Black population suffers at 16.4%, and the non-Hispanic white population suffers at 11.9%. And again, these are from the CDC's website. Overall, over the entirety of the US population, we suffer at about 10.5% from diabetes. So this is something that creates a huge cost on our healthcare system, both privately and socially. We looked previously at obesity and socioeconomic status, so now we'll take a look at diabetes and socioeconomic status. And this is where the numbers really, really are surprising. So this was a study completed by Dr. Su in 2012, and he took a look at healthcare system in the United States, healthcare system in Canada, healthcare system in Germany. And what he found through his statistical models is that poverty is such a large factor in the rate of type 2 diabetes that even in the presence of universal health coverage, it still increases your risk for the disease. So no matter what your access to care is, if you are of a lower income status, you will suffer at a greater rate from diabetes. Now, the other factors that influence the risk of diabetes, such as lower levels of education, unstable housing, and that can be multifactorial, literally an unstable house that is falling apart, or unstable location. If people are moving in and out of a house or moving from location to location, that increases your risk for type 2 diabetes. Toxic exposures, food access, security, and availability is obviously going to be a huge factor. And then again, like we talked about with Su's study, the access to healthcare may be a little conflicted because we've seen that even in the presence of good access to care, type 2 diabetes is still more prevalent in these lower income populations. And then affordability, quality of food, and then a big factor is social cohesion and support. And the people around you, how they're affected by the disease. So the associated comorbidities of type 2 diabetes, and these may be a review for everyone here, but I thought it'd be a good time to include some of the medical problems that we see with type 2 diabetes. Hypertension is a big one. Hypertension is often regulated by your kidneys, and as diabetes eats away at your kidneys, you start to develop hypertension, and then we send people over into chronic kidney disease and then eventually into kidney failure. Retinopathies or problems with the retina or other ophthalmic disorders such as cataracts are highly prevalent in our diabetes population. Hyperlipidemia or high cholesterol and high blood lipids, high triglycerides. The state of chronic low-grade inflammation that we see in like metabolic X syndrome, which we'll talk kind of briefly about. And then smoking is a major risk factor for type 2 diabetes. It impairs the way that your body is able to utilize insulin and utilize sugar. And then mental health disorders. So this one is kind of reflexively, type 2 diabetics suffer more from mental health disorders, and mental health patients suffer more from type 2 diabetes. So it can kind of be a chicken or the egg type of thing with mental health problems. This is kind of just a good overarching table of metabolic syndrome and its relation to the social determinants of health. So you can see on the left all the factors, all the risk factors, and this is not a comprehensive list by any means, that feed into this chronic low-grade inflammation that you can develop this metabolic syndrome. Hypertension, insulin resistance, oxidative stress, cholesterol, extra belly fat, high blood glucose, and then at the top, drugs and environmental toxicants. And up there, I would also include stress, environmental stress, home stress, work stress, and then the associated diseases that come out of this, either different neurologic disorders like peripheral neuropathies or polycystic ovarian disease, cancers, cardiovascular disease, type 2 diabetes, and eventually progressing into a mixed type of type 1 diabetes, strokes, and then a big thing that we see here in Oklahoma because of our Native American population is the non-alcoholic fatty liver disease, or NASH. So what our project was specifically was health education for patients suffering from type 2 diabetes and class 3 obesity, previously known as morbid obesity, at a federally qualified health center. And this was more of a quality improvement project. So the facility that we were working out of was in Olathe, Kansas, at a health resources center. And the facility has an abundance of resources. We had several different primary care providers. We had pediatricians. We had dentists. We had a good number of behavioral health practitioners. We had a diabetic educator, and we had a full-on diabetes clinic for our patients that were diagnosed with diabetes. But even in the presence of all of these resources, we still had a very large disproportionate numbers of chronic disease, specifically type 2 diabetes that was uncontrolled and class 3 obesity. And you would think that with the amount of resources, the diabetic education, the diabetic clinic, we would see these rates drop, but that just was not the case. So what we wanted to do is actually intervene with a health educator. And that's a role that we'll kind of talk about in a little bit. But we wanted someone who is dedicated to just discussing with patients how to be healthy, how to be active, how to make proper food choices in a timely manner so that they weren't stressed out by the primary provider coming in and only being able to spend 5 minutes with them talking about this. We wanted an extended period of time that they could talk with some of these patients. So to kind of set just a standard selection criteria for our study, we took type 2 diabetes, either new or prior diagnosis, and they had to have a hemoglobin A1C of greater than 6.5%. And if you don't know what this lab value is, we use the hemoglobin A1C to measure how the average blood sugar that a patient has over about 3 months. Anything between 5.7 and 6.5% we call pre-diabetes, and anything higher than 6.5% is considered diabetes. Now, if you have a diabetic that's at 6.5%, that's a pretty well-controlled diabetic. But we have diabetics that are 7s, 8s, 9s. I've seen 13s and 14s before too, which are very, very uncontrolled. And then for the same selection we wanted to do for class 3 obesity, we wanted to select a certain BMI. And that would be what was previously morbid obesity, now class 3 obesity, is that 39.9 on the BMI, which is measured across height and weight and calculated in that manner. So any BMIs 40 and greater are what we included. So again, the goals was to set a standard for health education in the federally qualified health centers. We wanted to identify resources for dedicated healthcare educator positions. And then we wanted to show that the health education position is a necessity in the FQHC and that it is very crucial to your treatment of type 2 diabetes and morbid obesity. And then the main goal is to help our patients just get better control of their weight and better control of their blood sugars and better control of their diabetes so that they can live longer and healthier lives. So our specific intervention just for the study was to identify a dedicated health educator for 1 month that would kind of float around the clinic. We offered health education to every patient in the clinic, but for the study purposes, we only included those that met the criteria. During that 1 month, we set aside 1 or maybe 2 meetings that were during a patient's normal visit. And then during that meeting, we did in-depth counseling on nutrition and exercise. Now, ideally for a health educator role, you would want someone who is already pretty knowledgeable in nutrition and exercise, whether that's a registered dietitian, a nutritionist, a personal trainer, athletic trainer, people that can fill that role. But we also included resources for them. So we have paperwork that we can also send out to where we had food lists and ideas for cost-effective grocery shopping. And we offered guided shopping trips to patients and offer them food choices and meal planning and recipes. And then we kind of did the same thing for activity, which you have to be a little more creative about, but we included cost-effective resources such as park gyms and at-home workouts that patients can do, along with counseling on schedule management and expectation counseling and the value of prolonged activity and setting long-term goals. So to put this just in perspective for an example clinic day, if you have a behavioral health person in your clinic, at least the way that we did at this FQHC in Kansas and how we do it here at the Chickasaw Nation, is we have behavioral health specialists that are kind of available on call to our clinic. So they're in our clinic, and if we have a patient that has a behavioral health need or they failed a screening, we're able to call that behavioral health person in and they can come in and see that patient right then. So we just mirrored that, that process with our health educator. We have the patient consent to the health education. And then after the provider is done and completed their visit, the health educator comes in and sits down with the patient for as much time as they need to go over the interventions. They were also provided paper or electronic copies of the resources that were available in the area. And then they followed up with the health educator either in-personally or virtually over the phone at 1 month, 3 months, and 12 months. In these encounters, the dietary interventions that we leaned toward were more a low starch or slow carb approach. Notice I didn't say low carb because it's a very, very hard diet to get these patients to be compliant to. But the idea is to focus on whole foods, primarily plant-based with unprocessed meat, and to minimize anything that's processed in a box or in a can in order to minimize any toxic exposure. And then stressing consistency and adherence being the most important factor, teaching these patients to not binge diet and then go back to their old habits and then binge diet again and then go back to their old habits. with the exercise interventions, again, you have to be a little more creative. So we set time goals initially. So 3 to 4 days of 15 to 30 minutes of high intensity exercise for most of the population. And then if you have patients that are a little bit more disabled, some of your older population, anywhere between 2, 3, maybe 4 days of 20 to 30 minutes of low to moderate intensity exercise. And the resources can be various depending on your area. And it was actually really surprising what we had in Olathe, Kansas, and around the Kansas City metro area. There was parks and outdoor gyms. Silver Sneakers is a program that's funded through Medicare, where it pays for gym membership for people over the age of 65. And there's other health facility programs like this. There's used gym equipment or weights or exercise equipment that people can have at home. And then really the main thing is just got to be creative when we're implementing some of these things, because remember, we're focusing on making this very, very cost effective for our patients. So our results, we had a very large clinic population, but during this month, we had a lot of issues with provider turnover and a lot of issues with follow-up. And that was just the nature of the clinic that we were at. There was some leadership turnover. So it did skew some of these results a little bit. I wish we had better numbers to bring. But 11 patients that we screened met criteria for BMI, and these were people that consented. We had a lot of people that met criteria for BMI and they did not consent to any health education. And due to provider follow-up and provider turnover, we had 5 of these patients follow up, and they averaged a BMI of 41.4. We had 17 people that we screened and consented to follow up with health educators that met that hemoglobin A1C criteria of greater than 6.5%, and only 7 of these followed up with an average hemoglobin A1C of 9.23%. So relatively uncontrolled diabetes. Again, provider turnover at the clinic made this a little bit difficult, but after the follow-up at 3 months, which it takes about 3 months to get an average hemoglobin A1C back. So our initial lab value follow-up was at 3 months. We had an average BMI decreased from 41.4 to 38.7 with a standard deviation of 2.82. And the hemoglobin A1C was decreased from an average of 9.23% to 8.06%, which was much more significant than the BMI. That amount of decrease in the hemoglobin A1C is very impressive. And that had a standard deviation of 1.78. So the big question is, how do we implement this? And we want to make this a template so that all community health centers are able to implement this easily and cost effectively. So the easy things that we're able to pass out today are food lists and exercise templates that you can give to your patients tomorrow if you want. The hard thing is finding a dedicated health educator, and there's several different ways that you can implement the health educator. The first is if you have the funds at your clinic and you're able to, a dedicated paid position would probably be the best way to go. But there is problems with funding and finding someone that's going to be a long-term health educator, because there's not a lot of vertical career mobility in the health educator position. With the resources that we had available in the Kansas City metropolitan area, we had multiple universities, medical schools, chiropractic school. There's a lot of students that are wanting to gain clinical experience. There's a subset of those students that are actually really well trained in exercise and nutrition. And if you can fill this position in an exchange for like an internship or clinical hours or something with some of these students, that is a really, really great way to fund this position for free, basically, and also offer your undergraduates and your graduate students clinical hours. So again, we can talk about, is access an issue or is information an issue? What we saw here is that we had a significant decrease in hemoglobin A1Cs and BMIs compared to previously, despite the fact that these patients already had very good quality access to care. What they were missing was one-on-one time health education to actually teach them how to implement the things that they already know they should be doing. So the project was to address this by providing a health educator, and the results showed significant improvement in these biomarkers. And our goal going forward is going to be to create a template for any clinic to implement this in a really cost-effective way. So here's the resources that we used, and we can open up for questions if we have time. I'll try and get this, this chat feature opened up. I saw a couple come in, but I wasn't able to see them.
I can read those out to you if you'd like, Dr.
Sure.
Smith. Okay. Helen asks, how do you reconcile using a notoriously racist and scientifically insignificant tool, BMI?
That is one of my least favorite, I would agree with that statement, is one of my least favorite tools to use. And it is pretty detrimental to our pediatric population, especially if you're a more athletic build, you're actually going to be higher on this BMI. Unfortunately, without the use of really expensive body fat measuring devices implemented in clinics, this is all we have. The best thing is to just assess your patient visually. So if you read that someone has a BMI of 40 and you walk in and you believe that you're looking at a relatively healthy person that doesn't have any comorbidities, they don't have diabetes, they don't have heart disease, all their labs look great, then you don't have to use that at all.
Okay. Next question is this a program that HRSA is recommending for FQHCs?
To my knowledge, this is not something that HRSA recommends. This was something that was piloted out of our FQHC.
Okay. Next question. With the push towards value-based care, why is this not being implemented at all FQHCs?
I agree. That was kind of our question after we saw how great the results could be. I would say the biggest barrier is funding that health educator role and making that health educator role a standard in the clinic, as much of a standard as you would a dentist or a behavioral health specialist or a primary care provider. I would put that health educator role as equally as important as all of those providers.
Okay. And last question here. Novo Nordisk has a wonderful book, Counting Carbs, that is very helpful in diet education. Just a resource for everyone.
Yeah, that's great. I have not read that book personally, but I will take a look at it.
Now we'll have our next presenter, Rocio Castillo-Foell.
Good morning, everyone. I'm going to start sharing my presentation. Just 1 second. All right, I hope that you can see my presentation. Good morning or good afternoon, everyone. Buenos días o buenas tardes, depending where you are joining us from. My name is Rocio Castillo-Foell, and I will be presenting today with Michael Vieyra, or AmeriCorps volunteer. So as I mentioned, I'm the Health Education Program Manager at CMAR Community Health Centers. And Michael.
And I am the AmeriCorps Vista member, and this is year 2 of the 3-year partnership.
Thank you, Michael. To start, I would like to tell you a little bit about CMAR Community Health Centers, and after that, we're going to be talking about a specific project that is called the Farmacia Project, a project that aims to increase access to nutrition, food combined with health and nutrition educations to patients that might have a higher risk for chronic medical conditions. CMAR Community Health Centers is located in Washington. It's a federal qualified health center, and it's a community-based organization committed to providing quality, comprehensive health, human, housing, educational, and cultural services to diverse communities. However, we specialize in offering services to the Latino community. CMAR was formed in 1978, so we've been in this area for over 40 years. Today, CMAR is one of the Washington's largest community-based health and human service providers. We have about 33 medical clinics, 21 dental clinics, and 28 behavioral clinics. And most of the people that CMAR serves are low income, very often below the federal poverty line. Every pin that you can see here is actually representing one of the locations where we operate. So part of the services that CMAR Community Health Centers offer is the health education. Michael and I are part of the health education program, which specializes in offering research-based education in chronic conditions to CMAR patients in a community and clinical setting. I have been in the health education program since 2014. For the first 4 years, I was a health educator in Whatcom County, where I learned a lot about the needs of the community, including the struggles of food insecurity and its connections with chronic conditions such as diabetes, prediabetes, hypertension, and everything that's now reported in the scientific literature as the metabolic syndrome. So for those who are not familiar with our county, is located in the upper part of Washington State, where CMAR has 2 medical locations, Bellingham and Everson Medical Centers, and Whatcom County is where we are located. In this specific county, many of our patients are actually agricultural workers, such as migrants and seasonal workers. We have about 30,000 farm workers in this area from different parts, coming from Mexico and in Latin America. During my time as a health educator at both clinics, I corroborated what I read in the local community health assessments done by the Whatcom Health Department. It's a sentence that I wanted to share here with you, which kind of struck me because notice the unfair differences in health and well-being. They persist, especially for youth whose second language is English, and for youth and adults with low incomes experiencing homelessness and people of color. So let me take a breath right here. My colleagues and I, who were part of the health education program, we observed that these communities that we were serving on a daily basis, providing health education, were those described in this community health assessment. We also noticed that despite the many, many hours that we could spend with a patient, explaining them what to eat or how to prepare their meals, the reality is that accessibility to fresh fruits and vegetables to improve their diet and prevent and control chronic health conditions was extremely limited. But before I continue with my presentation, I want to talk to you about food insecurity and provide you a definition. According to the United Nations Subcommittee on Nutrition, food insecurity is defined as the limited or uncertain ability of nutritionally adequate, safe foods, or the inability to acquire personally acceptable foods in social acceptable ways. We can see here that before COVID-19, actually, we have some data that show that in the United States, we have about 10.5, 10.9% in food insecurity, which actually was pretty low in comparison to 2018 and 10 years previous to 2019. So in 2018, it was about 11% in food insecurity across the United States. 2019, it was about 10.5, 10.9. But of course, this is before COVID-19. I think that once that COVID-19 happened, a lot of the issues were exposed. These ones are projections that actually just came out recently. They are from Feeding America. They were just released a few days ago. So after COVID, we're actually observing that it's about 11% in annual food insecurity rate. That could be translated about 35.2 million people is suffering food insecurity. For the projections for 2020 and 2021, we can see them here. It's about 14% in the annual food insecurity rate. And for 2021, it's projected to be about 13%. But unfortunately, you can see that food insecurity is actually going to be higher in the Latino community in comparison with Caucasian. It's going to be 1 in 12 white non-Hispanic individuals are going to be experiencing food insecurity in comparison to 1 in 6 Latino individuals. Unfortunately, I wasn't able to put here the rates specifically for farm workers, but based on the data that is reported, very likely farm worker families, they have an average an income between $17,500 and $20,000 per year. So you could really expect that food insecurity is actually very serious in this community in a specific. So why I'm talking about food insecurity and the stuff that Seymour Community Health Center has done to help the community that comes to us? Well, because there is a connection. The scientific literature has actually reported the connection between chronic conditions. And I have to emphasize, food insecurity is and it continues to be a public health issue that is affecting us as a society, and it's affecting especially those socioeconomically most vulnerable. These individuals might have higher risk to end up with a chronic medical condition, and therefore high risk for disability. So we can see here in my slide that, in several, but here in a specific one of the articles that I placed in my slide, it says that in a cross-sectional study, a number of findings suggest that a household food insecure is like to chronic diseases. And food insecurity is significantly associated with type 2 diabetes, particularly among Latinos. Many of these individuals that come to us, they also are suffering obesity or they might be overweight. And they get frustrated when they cannot lose weight. And unfortunately, this could be explained with a phenomenon known as the hunger obesity paradox that I'm going to try to explain to all of you in the next slide. So one way that we can explain how this paradox might occur is by mentioning that people who are exposed to food insecurity might present high levels of stress and depression. Fortunately, this could go in company of each other and might relate these individuals in high energy, dense food, such as comfort food. That this could be due to cost, it could be due to eligibility and other factors. Thus, the combination between stress, depression, chronic stress actually for not having enough to eat, and the ability to access just comfort food might suggest that stress activates the hypothalamic pituitary adrenal axis that is going to provoke the release of cortisol, which might alter the metabolic process of the individual. That means that in the bloodstream, you're going to have more blood glucose ability. It's going to be a higher excretion of sodium. It's going to be a higher retention of sodium, which probably could cause an elevation in the blood pressure, a higher excretion of potassium, and it's going to be a higher suppression of the immune system. So someone who is having a lot of cortisol, a lot of stress, it could potentially develop some metabolic conditions. In simple words, stress equal to increase the release of cortisol. This equal to increase the glucose ability in the bloodstream, and it's going to translate into an increase in the energy supply. Energy that is no use might end up affecting the visceral adiposity, which is associated with a strong risk factors for diabetes. Of course, this is just one of the mechanisms that could help us to explain why a lot of people that are suffering food insecurity might end up having overweight, obesity, and therefore having some metabolic issues. So this is a image that maybe some of you are familiar with. It was adapted by me from an article that was released by the New England Journal of Medicine back in 2010 by Slickman and Schlenker, where it talks about how food insecurity is going to kind of change different reactions in the community that is experiencing this situation. So the individual is going to end up having some coping mechanisms, right? That might be not going to be the best. When you're stressed, when you're dealing with poverty, you might not have the mindset to take the best choices. Of course, if someone already has risk for diabetes or hypertension, or perhaps already has a diagnosis, it might end up not taking the best decisions when it comes to take care of their health. So that's going to continue impacting the health status. This is the equivalent to increasing medical expenses, maybe lack of support, and maybe the individual could be a higher risk for disability. Of course, you're going to observe there's going to be some spending trade-offs. This individual might end up having a hard time deciding on, okay, shall I pay the rent? Shall I buy healthy meals that are recommended for me, or shall I pay for my medication? So it's a very complicated situation. So Zimmer Community Health Center, after seeing the evidence that exists supporting food insecurity and the connection with chronic medical conditions, we decided to give one step forward and create a program that could check a lot of the boxes that are here in my slide. We wanted to have an intervention that could be community-based, an intervention that could provide tangible resources to our patients to improve their diet. We wanted to make sure that the intervention that we wanted to create will involve medical providers, also that could eliminate or minimize the stigma around food banks or accessing to charity services. And we also wanted to have an intervention that could be culturally appropriate for the community that we serve. Remember, we serve mostly the Latino community. But we also wanted to have this intervention to be in a safe space. Remember that a lot of our farm worker people might be dealing with some immigration issues, and they might not feel comfortable go to a regular food bank. So we knew that we could not do it alone, even if we have a group of health educators supporting our patients. We wanted to have someone who can also be like the driver of this intervention. And that's why Zimmer Community Health Centers, through the health education program, partnered with the AmeriCorps program, and we created the Farmacia project. So now I'm going to let Michael talk more about the Farmacia project and what this has been in terms of impact for the patients that we see at CMAR Community Health Centers. Michael?
Hello, everyone. So as Rocio mentioned, I work under her team of health educators under the health education program with CMAR Community Health Centers. So if you want to just give me the next slide, please. So what is AmeriCorps? AmeriCorps is a federal agency that's focused on connecting individuals with nonprofit organizations to tackle the nation's pressing challenges surrounding the issues of poverty. The partnership lasts 3 years, and the sector that CMAR decided to partner with in AmeriCorps is the VISTA sector, and that focuses mostly on building capacity, which means that a lot of it is in direct service, so such as program implementation, program creation, program development, and this is all at the local level. And so I'm just going to go and give a brief overview of Farmacia and then break it down by each year of the partnership. So what is the Farmacia Project? It's a grassroots initiative. It's a patient-focused program, and it's a step towards increasing food access in Whatcom County. Again, we are serving the patients at the Bellingham and Everson Clinic. And so Bellingham, I saw one of the questions earlier in the chat, is located west of Whatcom, towards the west end of Whatcom County. And so these are a few of the partners that we have been able to build relationships with. So we have City Sprouts Farm, which is a local farm here in Bellingham, Food Lifeline, the Bellingham Food Bank, Christ the King Community Church, which also has a farm here in Bellingham, and Sustainable Connections. So during the first year of AmeriCorps, of the AmeriCorps partnership, Claire Milborn, she was actually the year one VISTA, was focused on creating a program. So what that means is that she researched the communities in need of increasing food access. She built relationships with partners, and she created a program that addresses food insecurity. During the first year of this partnership, it was 2019, and so that was pre-COVID. So the initial idea was to have a farm stand inside of the clinic that could provide produce to patients where they could just walk up and take what they needed. COVID, however, changed that. And so she switched to a farmer's market style distribution where still patients had the agency to choose the fruits and vegetables that they wanted to take. However, we had to switch and make it to a once a week program where they can take as much as they needed for the week for them and their families. And so here we have pictures of kind of how it started initially. You can see that the donations were on the smaller end. We had some canned goods and also some produce. And then she decided to switch specifically to only produce and whole foods. And this is kind of like the setup that we have here, where a patient would walk up, and of course, they couldn't actually pick out what they wanted, but they could tell us which vegetables they wanted, and we could pack them for them. So moving into year two of the project, I knew that I wanted to further develop the program and make it more sustainable and kind of make it so that patients knew this resource was going to be here every single week. They could take enough for the week, and we were going to be giving them as much as they needed. I have worked on securing partnerships and donations, surveying the community to receive feedback from the pilot year, from Claire's year, and also the start of mine. And I've created a plan for efficiency. So I've known that I wanted to take this program one step further, and what I mean by that is continuing to keep the integrity of having it be a patient-focused and involved program. So I really work on, building the relationship with patients that become regulars of the Farmacia to see what kind of foods they want to see at our program. So we serve predominantly Latinx communities, and so we have been asked for more like chilies or tomatillos or corn or more culturally appropriate foods. And so I've also created program guides, volunteer manuals, and applied for grants. So I know that another question was about funding, and that's really where the development of this program comes. It started with in-kind donations specifically, and that was done simply by reaching out to the local farms in the area, the food banks, and the nonprofits, and saying, hi, we'd like to start this program. We feel that we could reach a population that may not be as quick to receive food assistance from, organizations like food banks and nonprofits. that set up distributions as well. And I think that part of the reason why this program has worked so well is because CMAR has already established a really solid foundation of trust between its patients and its medical providers and health educators. And so I've also began working to create a plan for efficiency. So really maintaining a reporting system of how much food we're intaking and how much food we're distributing. And so I'm going to talk a little bit about the impact before I go over year 3, or the goals for year 3. And so the impact of the food pharmacy program, during the pilot year of the project, we were able to serve 1,455 individuals. This was over a span of about 6 months. And the program continues to increase accessibility of produce for patients that are living with chronic conditions and also facing many of the economic barriers set aside from the ones that have been or have surfaced as part of the COVID-19 pandemic. So here on the left, I have 2 sisters who collectively have a household of 10. They are unemployed and their husbands are also farm workers and were laid off in August. And prior to discovering our program, they were relying on fast foods that were very cheap and, not filled with nutrition. They did not have a diet that incorporated a lot of whole foods. And on the right, we have another patient that discovered our program, and she was denied from receiving SNAP benefits after applying 3 times. And she is the main person of the household. She takes care of her parents and of her sister, who are all unable to take care of themselves. And so she has been a regular at our program and really just grateful. I've heard countless stories from individuals of the community that are so grateful because they know that we're going to be there. They know that there's trust, and they know that we're listening to the things that they're saying. And this goes along with having them be introduced to new vegetables like leeks. A lot of the Hispanic population does not know what leeks were, and that's okay. So we kind of gave them small flyers and information about leeks, and it's been a way to kind of have the people who visit our stand feel a sense of community. Because we interact with them, they interact with each other in the sense of sharing recipes and, just talking about whether they liked mushrooms or not. So it's been really great to see all of that and to really continue to get their feedback and build a program that is focused on the patients we serve. And so for year 3 of the project, we will be focusing on sustaining the program. So creating a larger pool of volunteers, securing ongoing funding for the Farmacia program, and aiding health educators outside of Whatcom County in program implementation. And so because we have had a really great success here in Whatcom County, a lot of health educators across the state are interested in starting a food Farmacia program in their area as well. And so the Farmacia program will be coming to King County in the next month, and that's very exciting. And that is all for my AmeriCorps presentation. And so just go ahead.
Thank you, Michael. Yeah, so I just want to emphasize some of our conclusions before we open it for questions. So food insecurity has increased since the outbreak of COVID-19, and we have to continue emphasizing that food insecurity is a public health issue. And we already know that food insecurity is associated with higher healthcare expenses. And we have to create interventions that address food insecurity because it's needed, because we need to improve the health of our individuals or societies, and we have to reduce healthcare costs. And while we are creating this type of intervention, it's mandatory that we include the medical providers and healthcare stakeholders to create tangible solutions to reduce food insecurity and improve patient self-advocacy. And with that, we're gonna open to questions. Thank you.
So there are.
Okay, perfect. Yeah.
So there are some questions in the chat. So we have, is Farmacia a CMAR or AmeriCorps Vista program? So I can answer this.
Yeah.
So Farmacia is a CMAR Community Health Centers program. However, the partnership with AmeriCorps Vista is what has my role here. That's my role in the clinic, and my focus is the Farmworker program. So because of the partnership, they were able to bring somebody in to focus specifically on that program. And I work with health educators who are at the Farmworker program offering brief health education interventions to patients that are there. We also have, which staff usually apply for grants for this program. So this is kind of a mix between my work and also Rocio's work. So I do some research and I try to find grants and usually like the requirements and see if, you know, we can do, if we're able and eligible to apply. And then I'll send that to Rocio. And I don't know if you want to talk a little bit about that process.
Yeah, absolutely. So we apply for grants, we review them with the leadership at CMAR Medical Centers, but most of the fundings that we have for Farmacia are actually just, you know, people knocking on our door saying, hey, I have learned about your project, it's amazing, I want to collaborate with you, how much money do you need for a sustainability? So we've been extremely blessed, extremely lucky, but also we have worked so many years. You know, we have demonstrated that we are a center that is trusted in the community, that we work for the community. So we got for this year, for example, about $42,000 to make sure that the program is solid for 2021. Okay, and one more question. Do you want to answer that, Michael?
Yeah, so how receptive were local farmers to donating food, or was there some sort of compensation? So farmers are actually very receptive to donating food, and part of the reason why was because we kind of did our research and looked to see when farmers markets were, and then said, okay, well, if you have any leftovers after your farmers market that goes unsold, maybe you could donate that to our program. And that is what seemed to work the most. And also Christ the King Farm, they are a farm that focuses primarily on growing food for donation, and that's how we were able to also secure those donations. This upcoming year there will be compensation. We will be able to actually pay the farmers, but a lot of something that I've realized is all of these nonprofits and the farmers interested in addressing food insecurity really want to, you know, make a difference and try to help solve the issue. And so really just reaching out and beginning that conversation. City Sprouts Farm has wanted to find ways, even though they weren't able to be compensated, to be able to help us. And so they were planning on incorporating us into their crop schedule and into their like crop planning for the upcoming year.
So, all right.
Great. Thank you.
Sorry.
Thank you so much.
Thank you, Michael. Thank you, Rocio. I do want to briefly note everyone's attention to the chat. There is a link to the evaluation. If you could please take a moment and fill that out, that would be really helpful. And thank you both. And thank you, Ken, Dr. Smith, for your presentation as well. I'm not sure how much time they're going to allow us to go over. So,
yeah, we wish we had more time to talk to all of you, but thank you so much. Muchísimas gracias por todo, and hopefully you have enjoyed this presentation. Espero que hayas disfrutado esta presentación. Thank you very much.
Thank you.
Thank you.